Thanks for joining, everybody. We are very lucky to have Dr. Jonathan Gabison with us today. Dr. Gabison is an MCT2D content expert, a family medicine physician with clinical expertise in obesity and integrative medicine. He helps the coordinating center team for the Michigan Collaborative for Type 2 Diabetes, guiding the overall direction and care coordination for family medicine. So, Dr. Gabison is going to be talking today about our updates to the updates to the 2024 ADA standards of care. So without further ado, I will turn it over to you, Dr. Gabison.
Uh, Good morning, everyone. I assume everyone can hear me. Yes, my microphone is working. Hi. So these are just the introduction slides if anyone needs the CME information. And I'm sure it will be sent out by the MCT2D team. Some additional information. And then this is disclosures from our team. And here's the beginning of the presentation. So I'm again talking about the ADA Standards of Diabetes Care Update for 2024. I have no conflicts of interest. In today's presentation, I've distilled the key updates into 6 items to ensure that we focus on the most impactful changes. We're going to start today discussing the changes specifically to pharmacology. In case you're unaware, the 2023 update saw some major changes, which included this algorithm for use of glucose-lowering medications. Just to summarize the slide briefly for those who haven't seen the algorithm, on the left side, we prioritize the comorbid conditions, specifically cardiorenal risk reduction and heart failure, with those in type 2 diabetes with specific agents targeting those risk factors. If they do not have those risk factors, we look at glycemic management and weight management goals, the right side of the algorithm. Another major paradigm shift with this in mind is that metformin is not considered first line for everyone. In 2022, the standards removed cost and access from this table. And honestly, I would argue that's a mistake. The only change made to this algorithm in 2024 is that one small box that you see circled in red or squared off in red or rectangled off in red. They changed the word consider to prioritize for avoiding medications that can cause hypoglycemia in high-risk individuals. There's a lot of information on this slide. They have this table of all the medication classes and the evidence behind the different benefits and some considerations to make. We'll zoom in closer on some of the key updates. So for GLP-1 receptor agonists, it is now recommended that we counsel about potential ileus, specifically with subcutaneous semaglutide. It was also noted in the standards that for patients with advanced chronic kidney disease, so eGFR lower than 30, GLP-1 receptor agonists are the preferred medication option for glycemic management due to lower risk of hypoglycemia and for the added benefit of cardiovascular risk reduction. In the GIP-GLP-1 dual agonist section, tirzepatide is not recommended for individuals with history of gastroparesis. This was an addition. This is specifically because the pharmaceutical company made that recommendation, and not because of any updates in the literature or increased concern compared to similar medications in the GLP-1 receptor agonist class. Next on the agenda, I want to highlight the 2024 changes made to complication preventions, specifically focusing on blood pressure and cholesterol. To do this, we're going to start with a case. So JM, we saw JM last year, right after the 2023 update came out. We paid really close attention to the new algorithm after attending a really incredible MCT2D CME presentation. At the time of the appointment, JM had an elevated BMI. He was normotensive. His A1C was less than 8. LDL-C was 107. His EGFR was at 63, and he had a normal urine albumin creatinine ratio. He was taking metformin, glyburide, which is a sulfonylurea, sitagliptin, which is a DPP-4 inhibitor for his diabetes. He's on atorvastatin, or he was on atorvastatin for his hyperlipidemia, and amlodipine for his blood pressure. At that time, we decided to stop his sitagliptin and glyburide, and we started semaglutide to lower his cardiovascular risk and help support him in his weight loss goals. We started empagliflozin in thinking about glycemic goals and cardiovascular risk reduction and his EGFR. Because his blood pressure was well controlled, we didn't make any changes. And we increased his atorvastatin to 80 milligrams because his LDL-C was not at goal, which was, our goal was less than 70 per those guidelines. He then started to develop myalgias when we increased the atorvastatin from 40 milligrams to 80 milligrams over the course of the last year. And so we stopped the atorvastatin, the myalgias improved. We started pravastatin, and the myalgias reoccurred. At our appointment, let's say tomorrow, after this meeting, JM comes in, right? The first thing I want to highlight here is his blood pressure, which is 139/85, which many people look at and consider borderline. We should consider this high for a person with diabetes with chronic kidney disease. It's important to note that his urine albumin creatinine ratio is also elevated. His current medications are now metformin, 1,000 milligrams BID, semaglutide, empagliflozin, and amlodipine. So he's not currently on a medication for lipid management. In regards to updates for blood pressure. So I highlighted here some older management recommendations that are important to know. One, our goal should be lower than 130/80 for our patients with diabetes, as long as it can be safely attained. Two, I appreciate the effort that the standard spends talking about lifestyle modifications. And in this case, with blood pressure, it talks about the DASH diet and gives an A recommendation to the DASH diet, which includes limiting sodium and increasing potassium intake, moderating alcohol, smoking cessation, and increasing physical activity. A lot of us have learned this in the past, but ACE inhibitors and ARBs are first line for individuals with diabetes and cardiovascular disease, and that ACEs and ARBs also help to prevent progression of kidney disease and reduce cardiovascular events. The update in the 2024 guidelines is specifically, they recommend checking serum creatinine and potassium 7 to 14 days after adding an ACE inhibitor or ARB, mineralocorticoid receptor agonist, or diuretic. Many of us may have known that already, but this is more concrete than previous. In regards to lipid management, what do we do when our patients with diabetes have complications with statins? So I like this table, the robustness of the LDL cholesterol lowering effects of the statin medications, right? I like how it highlights how significant the lowering effects of these medications are. After failure of one statin medication or significant side effects, we should stop and try another medication, which is what we did with JM. The guidelines show that we should attempt to achieve a goal of less than 70. And for high-risk individuals, we should add an additional agent if that is not achieved. In the newest standards, people with diabetes intolerant of statin medications, intolerant of statin therapy, treatment with bempedoic acid is recommended to reduce cardiovascular events as an alternative. And this is new. This is a new medication. This is based on a study that came out last year that demonstrated that bempedoic acid therapy lowers LDL cholesterol by about 23% compared to placebo, and found that among statin intolerant patients, it significantly reduced major adverse cardiovascular events. So some notes on bempedoic acid. One, it's only good for modest lipid lowering effects, about 23%. Two, it works along the same pathway as statins. Three, it is noted that it can raise uric acid levels. So if someone has history of gout or elevated uric acid levels, we should consider stabilizing this beforehand. And then four, the people in the trial had a mean LDL cholesterol of 142. And so I would be cautious in applying bempedoic acid to patients with LDL lower than 100 for additional lipid lowering based on lack of generalizability. This is specifically patients who are intolerant to statins, and it showed that that improvement in major adverse cardiovascular events for that population of people. This is some additional information for bempedoic acid, the dosing, the formulation, and if anyone's interested, the mechanism of action. Okay, next on our agenda.
Dr. Gabison, there's a couple of questions in the chat specific to this
Yes.
case. If you'd like to chat, take a peek
Yes,
at those.
please. Sorry, thank you. Let me take a look. I'm chugging along and I had a brief interruption, so I got sidetracked.
No worries.
So why not use Zetia or PCSK9 inhibitor to address the lipids, right? So this is an additional option, right? Cost can be an issue. Prior authorization can be an issue. Zetia could be a good option, but this one showed reduction in major adverse cardiovascular events as an additional option. He was on Lipitor 10 milligrams initially. That might have been a mistake on my slide. He was on 40 milligrams initially and is and we increased it to 80 milligrams. That could have been an option to lower it to that dose. I was using that to highlight bempedoic acid specifically. And then he needed less than 70 and 10 Lipitor wasn't doing it. Thank you, Sarah. Oh, so this was a back and forth conversation. I agree, Sarah, that cost will be an issue for bempedoic acid. I was just using this to highlight specifically this update to the standards, right? So ezetimibe is something that can be used. The PCSK9 inhibitors is also something that can be used. The PCSK9 inhibitors haven't been shown independently to reduce major adverse cardiovascular events, not with a statin medication. With a statin medication, it has been. This has been shown without a statin medication. Next on the agenda, we're going to take a look at another case to talk about obesity and weight management. Good questions, everybody. So LK, she is a 33-year-old with past medical history of type 2 diabetes. She has an elevated BMI, PCOS, and she comes in to discuss her new diagnosis of type 2 diabetes. Her blood pressure, she was normotensive. A1C is 6.9%. LDL-C is 131. HDL is 38. ALT is 71. AST is 39. Her eGFR is greater than 100. She has no history of smoking or alcohol use, and she's not currently on any medications. This is taken from that right side of that algorithm. LK has a new diagnosis. She has no chronic kidney disease, no known cardiovascular disease. Our goal should be to focus on glycemic management and achievement and maintenance of weight management goals. Specifically, the algorithm highlights setting individualized weight management goals. I'm personally really happy with how the standards focus this year on the importance of what language we use and how we approach our patients. It specifically recommends using person-centered, non-judgmental language that fosters collaboration between individuals and healthcare professionals, including person's first language, like person with diabetes or person with obesity rather than obese person or diabetic person. Why is this important? There are consequences to negative healthcare environment for people with obesity. Weight stigma has been shown to increase eating, decrease self-regulation, increase resistance to exercise, raise cortisol levels. It leads to our patients avoiding medical care, mistrusting us, mistrusting the medical care providers, decreasing adherence to our recommendations, and overall poor communication. We can make same or similar recommendations around lifestyle or medication without focusing on BMI or weight if that is not what the focus is for the patient. When thinking about weight, having a magical BMI number or a weight number at the end, like a target number, is not necessarily conducive or supportive for the patient. We can think about weight loss as percentage, and it can lead to more attainable goals for the patient. So I often talk to my patients about the importance of behaviors in our day-to-day life around any condition, right? And I don't necessarily focus on weight, but if they come to me to talk about weight, I describe how weight loss will correlate with these behavior changes, and with that correlation, we'll see certain improvement in health outcomes that we want to achieve, right? So we'll see that when someone loses 3 to 7% of their weight from their starting point, they'll have improved glycemia, improved cardiovascular risk factors like hypertension and dyslipidemia. If they have greater than 10% weight loss, they'll have disease-modifying effect on their type 2 diabetes. They'll have improved cardiovascular outcome and mortality. The emphasis needs to be on their individual treatment approach and what's important to them, what's important to their medical history and their circumstances and their motivations. The standards added some recommendations to nutrition management. So it talks about how there's no one-size-fits-all eating pattern. and calls out certain patterns of eating, like Mediterranean style of eating, and the importance of healthy fats. I appreciated how it called to made a call to chrononutrition, which is how time in which we eat can have cardiometabolic effects. And then specifically highlights how shift workers have increased risk of type 2 diabetes. The standard also added a section on religious fasting. Ramadan has just started on March 10th. So it's important to ask our patients if they are engaging in fasting and provide education and support to help accommodate this choice. This app on the right, DAR Academy, is an app that has a really handy risk tool that assesses multiple risk factors for safety for patients who may engage in fasting who have diabetes. So hypoglycemia or agents that can cause hypoglycemia is a big one, but also frailty factors like age and bone health can also be big factors as well. The standards updated medication treatment, specifically by listing sub-Q semaglutide and tirzepatide as preferred pharmacotherapy treatments for people with obesity. And it also extrapolated or expanded its section on metabolic surgery as an option for people with diabetes and obesity. Metabolic surgery can help prevent and address therapeutic inertia pertaining to weight management goals in people with obesity and in type 2 diabetes. And there continues to be long-term evidence in those with these conditions. There was also a section that was added discussing the importance of monitoring our patients who have had metabolic surgery in the past and making sure that they're continuing maintenance of weight loss. And if they're not, what are those barriers? Addressing those barriers, and if there are additional interventions that we should be considering. I see that Shona asked me a question, any update recommendations on treatment for Medicaid patients? Is that specifically for obesity related? So this is constantly, like within the state of Michigan, it's just constantly changing, and a little bit outside of diabetes specific, but right now they stopped covering Contrave and Qsymia, and they cover Wegovy, which is so hard to get. They cover the GLP-1s. The MCT2D website has a coverage guide for obesity. Thank you, Dr. Oshman. Next on our agenda, we're going to talk about health behaviors, and with that, another case. LA is a complicated patient. He has history of transplant and medication fatigue and chronic pain. His A1C is has been worsening. It went from 8.0% 6 months ago to now 12.5%. And when you see him, he says, "Doc, I'm just tired of these medications. I'm in pain all the time. I am exhausted." The standard has made some changes to, or has discussed more thoroughly and made new recommendations to increase frequency of screening for diabetes distress. it recommended routinely assessing all people with diabetes for financial challenges and recommended at least annual depression screening for people with diabetes. If you all received these slides before I made this next slide is an updated slide that I just made earlier today because I wanted to talk a little bit more about diabetes distress. Diabetes distress refers to significant negative psychological reactions related to emotional burdens specific to an individual's experience in having to manage the severe, complicated, and demanding chronic condition that is diabetes. So there was a study, the DAWN-2 study, that showed that significant diabetes distress was reported by 45% of the participants, and only 24% reported that their healthcare team asked them how diabetes affected their lives. High levels of diabetes distress impacts medication taking behavior and are linked to higher A1Cs, lower self-efficacy, less optimal eating and exercise behaviors. And it's also associated with symptoms of anxiety and depression and reduced health-related quality of life. The standard also cites this PAID scale on the right, which is a screening tool that we can use to assess for diabetes distress. So after further investigation, LA is tired of frequent finger pokes and he's worried about hypoglycemia events, which leads to our next subject, diabetes technology. So the standard updated its content on diabetes technology. It recommends that all people with diabetes should be offered a diabetes device. CGM should be offered for diabetes management in adults with diabetes on multiple daily injections. This is real-time CGM, which is continuous. It gives an A, and then intermittently scan CGM. So doing it off and on, it gives a B rating. CGM should be offered for diabetes management in adults with diabetes on basal insulin. And then in addition, there is evidence that supports reduction in A1C levels and reduction of time in hyperglycemia for patients that are not on insulin. I'm just checking to see if there's any questions. Okay, so next on the agenda is improving population health. So this is a few more topics, specifically updates in heart failure, bone health, and liver disease that were some changes that were made to the standards. So heart failure screening, I found this really, really interesting. The ADA recommends to consider screening for people with diabetes, type 1 or type 2, for heart failure with BNP. This caught me off guard because this is not something that I've thought about doing in primary care. The rationale behind this is that all people with diabetes have an increased risk of developing heart failure, and that heart failure is a very common complication, and there's been increased incidence rates. This is an algorithm that came from a consensus report published in 2022 that recommended this yearly screening. And if the BMP was elevated, the recommendation would be to get an echo. After getting the echo, if there's any structural abnormalities or signs of asymptomatic heart failure, then we have the option of initiating potential treatment now that we didn't necessarily have before with SGLT2 inhibitors, which is the value of doing the screening early. And the SGLT2 inhibitors would be recommended to reduce progression, reduce heart failure, hospitalizations, and cardiovascular death, even in patients that have asymptomatic heart failure. I found this to be a really interesting addition. And in reading about this, I found it to be shocking, and I'm still debating whether to do it or not. But the more I read about it, I understand why they added it, just because if we have an intervention that we can do for a patient that wouldn't be on an SGLT2 inhibitor, now we have a medication that we can add on that can be helpful. Maybe that additional test, an add-on lab, can be helpful for that patient. So I think I haven't decided if I'm going to do it regularly or not yet, but I think that it's just something that's interesting to think about for some of our patients. Next, bone health. There was a lot added on bone health. So people with diabetes have an increased risk of hip fractures, worse with certain, worse with worsening glycemic control. Individuals on certain medications, so TZDs, sulfonylureas, insulin doubles the risk of hip fractures. Metformin, GLP-1 receptor agonists, DPP-4 inhibitors, and certain SGLT2s don't have, SGLT2 inhibitors don't have that increased fracture risk. Canagliflozin is an SGLT2 inhibitor that has one study, the Canvas study, that showed increased fracture risk. So the recommendations on bone health is they recommended monitoring patients, individuals with diabetes who are 65 years old or older with a DEXA scan, or younger individuals with diabetes who have multiple risk factors. So what are those risk factors? Prior osteoporotic fracture, low BMI, female, recurrent falls, steroid use, family history, alcohol, tobacco use, history of rheumatoid arthritis. There's certain diabetic risk factors, frequent hypoglycemic events, increased diabetic duration greater than 10 years, certain medications like the ones that I highlighted, A1C greater than 8%, history of neuropathy, retinopathy, nephropathy. Prioritizing certain medications that have that neutral profile, like I mentioned on the previous slide. And anti-resorptive medications and osteoanabolic agents should be considered in patients with a low bone mineral density. So finally, the standards have a B recommendation to incorporate screening for liver disease by recommending screening for liver fibrosis with a FIB-4 score, even if a person has normal liver enzymes. And that the FIB-4 includes age, ALT, AST, and platelets. This is an algorithm taken from Diabetes Care ADA call to action for the NASH epidemic that recommended this for every 2 to 3 years. And if low risk, repeat every 2 to 3 years. And then if indeterminate, they can be further stratified by getting a liver stiffness measurement. I zoomed through that lecture, so we have a few minutes. We have about 5 to 10 minutes for questions.
There were what looks like just a couple of FYIs put in the chat. Dr. Gavison, I saw those.
Yeah, I'm looking at them now. I'm zooming them in because it's hard
There
to
you go.
see. I would have loved to see that lecture, Sarah. Yeah,
Yes, it was given yesterday as part of the Echo series out of New Mexico. So I can forward that along if interested.
yeah. I did a lot of reading on this because it's not something that was in my it wasn't something I was actively thinking about as a screening option. And I after reading what they were saying and then reading the studies that the standards was citing, I might be shifting my attention. BMP is not a very expensive test. I think about how that would affect my patients, and catching something a little bit earlier, if we can halt progression of heart failure, would be a really big thing for our patients, right? And SGLT2 inhibitors, I think, it can be helpful in that, and we're not increasing the risk of hypoglycemia or something like that. So I think there's value to it.
And yeah, and the next slide that I posted is really interesting because they noted the incidence in those over 60 years old. So that may be where I start.
Yeah, it's reasonable. So the chrononutrition, there's not a lot to elaborate. So there's increased risk of type 2 diabetes in shift workers, and then patterns of eating. So, people who eat later at night there's small limited evidence that shows that can have effect on their glycemia. So having eating along with the circadian rhythm, having meals more along with daytime, I feel like is an intuitive idea, and there's some studies that are showing that and bearing that out. Marcus, I am not sure about that. So Marcus is asking if there are thoughts or information on using SGLT2 inhibitors in a controlled type 1 diabetic with heart failure. I have not heard anything about that. And I think that is a really good question. So once on a GLP-1 receptor agonist, is a patient on it for life? And if a patient goes off of it, is the weight regain worse than before? I love that question. That is excellent. The answer is, according to the evidence, I would argue that there is weight regain, but that's based off of the evidence that's provided to us, right? And so that's what's been studied so far, especially for individuals with obesity. Specifically Wegovy studies and Saxenda studies and Zepbound studies. I'm sure we're going to see that too. I think my criticism of and the other weight management medications as well. My criticism of these studies or of these companies is that we should be thinking about these long-term implications, and that I would love more support in thinking about how to get people off of these medications once we have a goal met. I have ideas about it, but there's not it's not borne out in the literature, and so I can speak off the cuff about it, but I have like some patients who may be stretching out these medications, not every week, but maybe doing it, changing those intervals, or we slowly go down on the dose and trying to keep weight stabilized and seeing how things kind of bear out. Sharon, it's, after 1 year off of the medication, weight regain is about 75%. Thank you for that, Sarah. That's very helpful information. So, I when I'm thinking about nutrition, I think I primarily focus on minimizing processed foods and minimizing complex carbohydrates, right? So the breads, pastas, rice, those kind of foods. I don't really, I think that when someone can commit to a very low carb nutritional pattern, we can try that. But if it's something that they can't commit to, if that's something that they can commit to long term, then an SGLT2 might not necessarily be a medication that would be good for them in the first place, and they might be able to control their diabetes with nutrition alone. But a lot of people, it's a hard concept to commit to something like that long term. So I really focus on the minimizing the foods that got them to the diabetes in the first place. That was Mary's question. Did that answer your question, Mary?
Yes, yeah. I'm a nurse, so I'm always looking to hear different points of view on this, and I really subscribe to the there's no one-stop shopping for dietary advice. You really have to tailor it to your patient. But I once heard someone use the terminology a healthy relationship with carbohydrates in their life. And I really liked that. I like to adopt that approach more, but I have had a couple patients end up in the hospital with ketoacidosis. They were on an SGLT2 and they really over heavily, I guess, restricted their carbs. And then you read that is a possible complication. And I'm like, I guess it is. I'm living it. So I'm just, one other thing just quickly is I find that there is a lot of diabetes distress related to so many different opinions, I guess, or different presentations of our recommendations. And I think the closer we can adhere to what the ADA recommends, I think it's just better all the way around. Otherwise, there's so much distrust, there's anxiety. So I guess that's an area that I'd like to see a little more coming together on, because I think that's an area now that you can read everything you want on TikTok and Instagram. And fact is, that's where a lot of people get their information, So anyway, thank you for answering that, sir.
Yeah, I think, one of the complicated things about food, and I think Lauren Dr. Oshman made a point to this, is especially processed foods have such a neurologic effect on us, and it's hard to limit sometimes. I feel like when we when our patients develop diabetes, it's usually when it gets particularly things move along pretty far along at that point. And so when we remove some of those processed foods, we have an impact on the brain chemistry to help us over time. I have a lot of thoughts about the behaviors around those kind of things as well. And I think you can have a healthy relationship with carbohydrates, but if you're having them all the time, I think it's a struggle. Anyways, I diverge.
Yeah, then it's an unhealthy relationship.
Exactly.
So yeah, I guess I agree with you. So many of our behaviors are centered around food, and so many of the things we do are they're just food everywhere. You can't watch a Super Bowl without needing a Big Mac or a Pepsi or whatever.
Exactly.
So to help people live in the world we live in, and fact is we don't have markets that we can walk to like they do in Europe. We just need to help people navigate what we have and still keep their family traditions, their cultural traditions, their ability to go on vacation. That's what they tell me. I can't go on vacation. I can't go to my family's house for Christmas. I'd rather see us more focused on that and helping them find what they can eat and how they can even maybe taste a little bit of that pumpkin pie, as long as they don't do it right after a plate full of mashed potatoes and stuffing and, sitting watching the Lions. Go for a walk first, have some water, and then slowly, mindfully eat the pie. So I just really appreciate that. Thank you, sir.
I'm going to stay on for a few more minutes in case there's any other questions.
If no one's gonna ask, is it okay if I ask another one without typing? Because I'm a terrible typist.
Yeah, no worries.
Okay. So I know last year federally we were able to bring the cost of insulin down to $35. And I know the next thing on the agenda were, I believe, SGLT2s and DPP4s. I kind of wish it was the GLP-1s, but I think there's pushback from the drug companies. Is there any note of a time frame on that? Because that is a huge barrier.
I don't have any additional information than you do. I read the news.
Hi, Jonathan, it's Heidi. They are negotiating prices in 2025, and hopefully our patients should be seeing these prices come to fruition in 2026.
Thank you. Thank you. And one last plug. I really wish that they would start to let people have coverage for CGMs without already having to have 2 level 2 hypoglycemic episodes or being on insulin. We're getting closer, but whatever we can do, sign every petition you can, but why not for prediabetes or even people with obesity? I mean, it's life-changing. That's what people use that term, life-changing, to just 2 weeks of those. So I know there's a toolkit that's available, but again, you have to have the right insurance and all the right criteria, but hopefully
Mary,
Medicare will come to that.
You're doing our work for us. But I actually really appreciate the work that the leadership of MCT2D does in this realm specifically. They've been advocating for CGM coverage more robustly, and it's something that is really appealing. Like, it's really impressive, and I really appreciate the work.
But Dexcom is supposed to have an over-the-counter CGM. I have no idea about when or price, but
Stelo, it's coming out in the summer.
Okay. Do you know how much about?
I heard $70 to $80.
Okay. Thanks.
Regarding Ashley's question, I believe that this new over-the-counter Dexcom will be an integrated system, just like the G7 is and the Libre 3 will. So it'll be sensor and transmitter in one. Cost, like say, is going to be the big question. Obviously, patients with diabetes can be prescribed a CGM and then pay for it out of pocket if insurance doesn't cover it. So the only reason that the over-the-counter would be beneficial to folks with type 2 diagnosis would be as if it's cheaper in cost than, say, the Libre 3 would be with a prescription.
All right, guys, I am going to run to my clinic.
Heidi, can you answer Kim's or just address Kim's comment in the chat here about the prices for Medicare only, or if that'll trickle down to commercial?
Yeah. At this time, the way the IRA is written by President Biden, it's for Medicare, but during the State of the Union address, he mentioned, especially for the insurance, like deductible caps for out of pocket, he wants to make an effort to move that beyond Medicare to commercial plans. But again, that's the hopes and dreams. So we all hope he gets there.
Awesome. Thanks, Dr. Dees.
All right, everyone, thank you so much.
Thank you.